Good morning, my name is Dr. Cynthia Magro. I'm the Director of Genetic Pathology for Weill Cornell Medicine. Welcome to our interesting case presentation. So today's case is entitled Oligolesional Pustular Vasculitic Rash in Association with Odonophagy. So the patient is a 78-year-old male who presents with a 4-week history of testicular pain and swelling, migratory arthritis, scattered vesiculopustular and purpuric lesions in the feet, tips of the fingers accompanied by oral ulcers and difficulty swallowing along with pain in the throat. The laryngoscopic examination disclosed ulcerations of the epiglottis, aryepiglottic folds, bilateral true and false vocal cords, and edema of the piriform sinuses. There was also bilateral injection of the conjunctiva. The clinical impression was one that strongly favored an infectious-based etiology. Among the considerations were monkeypox, herpes simplex, and varicella. A skin biopsy was obtained and was submitted for both H&E assessment as well as direct immunofluorescence. So this is a picture of the skin lesions. There were these very distinct scattered pustular lesions on the tips of the fingers. He also had some lesions distributed on the arms, although I don't have any clinical images of those. And of course, when you see these isolated lesions on the fingertips, certainly one has to consider septic vasculitis, which was part of the clinical differential diagnosis. So what did the biopsy show? Well, it was a punch biopsy, and there was this discrete zone of inflammation, and as well, you can see that the inflammatory process is obviously involving the epidermis. The epidermis itself has this hypereosinophilic quality reflective of epidermal necrosis. So basically you have this necrotizing inflammatory process with significant injury to the epidermis. So let's look at higher magnification. What does one see? Well, here you have remnants of the epidermis. It is diffusely infiltrated by neutrophils. There is obviously ensuing epithelial injury. Within the dermis, one sees clear-cut evidence of a vasculitic process. There is mural fibrin deposition within capillaries and venules, accompanied by red cell extravasation, and there is a background of significant angiocentric and interstitial neutrophilia with marked leukocytoclasia. So essentially what you're defining here is what I would refer to as a small vessel vasculitis, a leukocytoclastic vasculitis, but with significant intraepidermal and dermal neutrophilia consistent with a pustular vasculitic process. Now, under higher magnification, there are some very important clues regarding the etiology of this vasculitis. Over here, one sees this basophilic smudgy material, whereby superimposed on it are disintegrating neutrophils. And to me, that is a characteristic hallmark of what one sees with neutrophilic extracellular traps as one might encounter in an ANCA positive vasculitic syndrome. And it is very characteristic when you see the neutrophilic extracellular traps to observe something very distinctive in the microvessels adjacent to these zones of net formation, which is vascular injury. And you can see how these blood vessels exhibit prominent mural fibrin deposition with vascular compromise. So to actually prove that these basophilic areas with superimposed disintegrating neutrophils in fact represent neutrophilic extracellular traps, which I'll discuss with you in detail, there were certain immunohistochemical stains that we were able to perform. When you think of a neutrophilic extracellular trap, I think it is important to understand what its basic composition is. It is really the release of the contents, the cytoplasmic contents of the neutrophil, like myeloperoxidase, proteinase 3, the release of nuclear DNA into the interstitium admixed with immunoglobulin. So how does one show the in vivo neutrophilic extracellular trap? Well, first of all, the basophilia is probably due to released nuclear DNA into the extracellular interstitium, and a PTAH stain, which is the phosphotungsten acid hematoxin stain will actually highlight the nuclear DNA that's released into the interstitium in a basophilic fashion. That's number one. So we can actually show that that basophilia is in part due to nuclear DNA. However, fibrin also stains blue, so it's not really a specific nuclear stain. We also did colocalization studies for immunoglobulin and myeloperoxidase. The myeloperoxidase was stained with a red chromogen, and the immunoglobulin of IgG isotype was stained with a diaminobenzidine technique. And one can see this sort of rusty color that clearly indicates the colocalization of myeloperoxidase and immunoglobulin. So in essence, what I've been able to show is that that area that I interpreted as a neutrophilic extracellular trap, in fact, is that immunohistochemically. So what does all of this mean in terms of the diagnosis? Well, there was evidence of in vivo neutrophilic extracellular traps. There was significant microvascular injury characterized by mural and luminal fibrin deposition, hemorrhage, and endothelial necrosis adjacent to the zones of netosis. And there was significant undermining of the epidermis and dermis in association with prominent neutrophils. So I think the combination of epidermal pustulation, the degree of extravascular neutrophilia, and small vessel vascular injury would certainly be consistent with a pustular vasculitis. The pattern of net formation, which we proved immunohistochemically, juxtaposed to damaged vessels, is characteristic for an ANCA positive vasculitic syndrome. Now, it turns out that I have seen approximately 3 other cases very similar to this patient, where these patients had few digital vasculitic lesions resembling a septic vasculitis, along with this very characteristic involvement of the oral cavity and the upper airway, with a histology that was virtually identical to what we see in this particular case as well. And the findings, all those cases, those other 3 cases, represented hydralazine-associated ANCA-positive vasculitis. So with that in mind, I actually contacted the clinicians and I asked them, is there any chance that this patient was taking hydralazine? Because it was just a very high index of suspicion from my perspective that perhaps this patient had hydralazine associated ANCA-positive vasculitis. And as it turns out, in fact, he was on long-standing hydralazine. We then did the subsequent serologic studies that would support this diagnosis, which was, number 1, is that he certainly did have a positive ANCA with antibodies to myeloperoxidase and proteinase 3, and it is very typical in hydralazine ANCA-positive vasculitis to see antibodies to both myeloperoxidase and proteinase 3. He also had anti-double-stranded DNA antibodies and a very high anti-nuclear antibody. So what about hydralazine-induced ANCA-positive vasculitis? Well, there are older patients, usually on long-term hydralazine. The predisposing factors are higher doses and reduced kidney function. There are highly reproducible findings from a clinical perspective, which include the isolated acral lesions mimicking septic vasculitis and pretty significant oral, laryngeal, and esophageal involvement presenting as ulcers. And the serologies typically show antihistone antibodies, and the ANCA is characteristically to both myeloperoxidase and proteinase 3. So it's a dual ANCA positivity. And these are just images from other cases that I've seen, and we've published these cases, showing the discrete oral ulcers and the scattered isolated pustular lesions, including the oligolesional process affecting the fingertips. So really, it is an interesting syndromic complex that is quite reproducible from case to case, basically. And this is another patient, so this is now a third patient, where you can once again see these distinct oral ulcers and the oligolesional septic vasculitic-like lesions on the fingertips. And not surprisingly, when you look at the histology, it's very similar to what we saw in this particular case, where you have the neutrophilic extracellular traps characterized by that basophilic smudgy material with superimposed disintegrating neutrophils, and the actual neutrophilic extracellular trap is really evokes endothelial cell injury that then results in activation of the clotting pathway, leading to luminal mural fibrin deposition. So I've always found this interesting dichotomy between the cellular neutrophilic extracellular traps and the adjacent damaged blood vessels, where the blood vessels themselves are relatively pussy inflammatory. So it's an interesting morphologic pattern that I have encountered over the years in patients with this particular type of ANCA-positive vasculitis. So what about the role of NETosis in the actual pathogenesis of the ANCA-positive vasculitic syndromes? So NETosis, again, equals neutrophilic extracellular traps, and it is really a mixture of nuclear chromatin released from degenerating neutrophils admixed with various neutrophil-derived proteins like proteinase 3 and myeloperoxidase, along with immunoglobulin. We do know that the anti-neutrophilic cytoplasmic antibody, when it binds to the displaced surface antigen, by that I mean the intracellular antigen like the myeloperoxidase or the proteinase 3, with apoptosis, it's displaced to the surface, allowing the ANCA to bind to it, and that causes the respiratory burst and ultimately autodestruction of the neutrophil. And we know that the NETs play a critical role in the pathogenesis of the ANCA-positive vasculitis because it actually causes endothelial cell injury with resultant thrombosis. And obviously I showed you several images, or at least a few images, of the NET juxtaposed to those thrombosed injured blood vessels. So drug-induced ANCA-positive vasculitis is among the prototypic small vessel ANCA-positive vasculitic syndromes, along with granulomatosis with polyangiitis, formerly designated as Wegener's granulomatosis, microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, which was formerly designated as Church-Strauss disease, and idiopathic crescentic glomerulonephritis. The ANCA is actually an indirect immunofluorescent assay where the patient's serum is incubated with alcohol-fixed neutrophils along with fluorescinated human anti-IgG. A C-ANCA defines a very specific indirect immunofluorescent pattern where there is accentuation adjacent to the lobes of the neutrophils, so it's cytoplasmic with interlobular accentuation, and that corresponds with antibodies to proteinase 3. In terms of the P-ANCA, the nuclear lobes of the neutrophils are outlined, and when there is extension of the staining into the nuclear lobe, there is a very strong correlation with antibodies to myeloperoxidase. When the staining simply outlines the nuclear lobe very sharply without nuclear extension, there is usually no correlation with antibodies to myeloperoxidase. We have so-called atypical ANCAs, where the fluorescence is flatter and there is no interlobular accentuation or accentuation around the lobes of the nucleus of the neutrophil, or there could be a combined cytoplasmic and perinuclear staining pattern, whereby there may be multiple antigenic specificities like antibodies to proteinase 3, myeloperoxidase, elastase, lactoferrin, etc. And so this is just a collage showing the different types of indirect immunofluorescent patterns that we see when we incubate the patient's serum with alcohol-fixed neutrophils. Here you have the classic C-ANCA with proteinase 3 specificity, where it's accentuated around the lobes of the nucleus of the neutrophil. Here you have a P-ANCA where the staining is very sharply outlining the nuclear membrane of the neutrophils without extension into the nucleus, and that would be a P-ANCA without myeloperoxidase specificity. Whereas here you have outlining of the nuclear lobes, but there is this bleeding into the nucleus of the neutrophil, and that would be a P-ANCA with myeloperoxidase activity, as one would see with a patient who has eosinophilic granulomatosis with polyangiitis. So the question is, how does hydralazine actually cause ANCA-positive vasculitis? Like, why would hydralazine induce the formation of anti-neutrophilic cytoplasmic antibodies in the first place? Well, the drug is metabolized, interestingly enough, by myeloperoxidase released from neutrophils. And it is possible that an intermediary compound is formed that could function as a hapten for myeloperoxidase, creating a state of neoantigenicity, hence inducing antibody formation through epitope spreading. The other main mechanism is in the context of hydralazine as a hypomethylating agent, resulting in reduced methylcytosine and the formation of autoreactive CD4 positive T cells. Hypomethylation results in loss of epigenetic immune tolerance and upregulation of endogenous retroviruses. And so that's it. That's our case presentation. I hope you found it very interesting. I think this hydralazine-induced vasculitis is quite fascinating. And once you see a case, you should be able to recognize it because of its reproducibility, not only clinically, but from a pathology perspective. Thank you for your attention.